So my topic is a nutrition in special situation, and it's quite a heterogeneous topic because only the binding link over is the nutrition. So, so that I'm not endorsing any brands, but telling the brands is a part of this because there are very limited options available. So I'll be covering nutrition in special situation. It's a long topic. I'll try to rush fast and try to cover as many as I can. So I'll be covering mainly about the percutaneous endoscopic gastroscopy. That is how we specially intervention for achieving the enteral nutrition. Involved of metabolism, nutritional aspects of that, short bowel syndrome and surgical one, neonatal cholestasis, and if possible, the milk protein allergy. So, so in the workshop from yesterday, you must be knowing how you are assessing the nutrition. So nutrition assessment, I'm not going much detail, but it doesn't stop at the anthropometric assessment. In neonatology, is a different parameters, but apart from that, we can also assess it by biochemical markers. There can be instrumental evaluation, and also in the elder ones, or even the functional assessment like hand grip strength and the frailty. There are no few studies even in the children for about the hand grip strengths, though it's not been standardized. Now, let's go to the topics first. So, this is basically percutaneous endoscopic gastrostomy tube feeding. So basically, main indications are when there is indication for the gastric enteral feed and the particular patient is not able to take it and orally, then yes, and then the stomach, and suppose sometimes you want to do a stomach decompression. These are the basic main indications. There can be multiple causes for which we might have to do it. The contraindications are if there are serious coagulation disorders, hemodynamic instability, sepsis, severe ascites, peritonitis, some interposed organs, gastric outlet obstructions, gastroparesis. These are the major contraindications. And yes, any procedures can have some complications as well. That can be the major and minor. If properly done, major complications are rare, but minor like wound care and all these generally are sortable. So generally, we don't find this major complications if the procedure is done well and they are followed well. So advantage is basically it's a low cost intervention, less invasive. This can be placed without general anesthesia and no need of laparotomy. So it's a save cost and steam. Generally, so the indications in the neonatologies are different, but for the older infants, if you are having any disease where the disease is not curable, and there is no, if your child is requiring a nasogastric feeding more than 6 to 8 weeks, generally we advised to go ahead with the gastrostomy tube feeding because of several advantages. One, so with a persistent tube can cause increase the reflux. Then there is a nasal blockage, and also of those patients who are as the neurodevelopmental issues, the caregivers' feeding time is significant. It goes to 30 minutes, 45 minutes, or in the recurrent pneumonias. In those special situations, we do advise them to go ahead with the pective insertions. So there are different methods like the pull technique, push technique, and either you can use the newer one, that's the introducer technique. The pull technique is very simple, and we do it in a endoscopic suite. We don't need an OT. So we just after the endoscopy, we select a transilluminated area in the epigastric region. This procedure is performed under strict aseptic precautions. And through an endoscope, we go into the stomach, and the needle is basically inserted into the stomach, and a guide wire is through a forceps which is introduced to the scope. Guide wire is pulled into at the mouth, and then a tube. This is a PEG tube which is pulled from the skin surface in the epigastric. That's a pull technique. Push technique differs from the second stage, where instead of pulling it, similar tube is pushed inside. So I'll just show a video. So here I am in this the stomach, and one forceps is there. Indentation is seen and the stomach. Then a needle is introduced. And then a trocar is kept there after the needle introduction. The guide wire is then grasped with the help of a snare or forceps, whatever the assembly you have, and then it is taken out. So it's very simple procedure. And once the guide wire is out from over the guide wire, you can one can basically uh, pull the tube. Only the issue is there is a risk of oral contamination. So the procedure antibiotics will be required. So it can be easily done. So this is how the tube is placed. So this is quite an older cage. Generally, we are till 7 kgs and all. This is the youngest we have put. But even in the 3.5 kgs kids, it can be placed. And for this age, generally a 12 French tube is sufficient. So the advantage are it avoids aspiration. One can give a balanced diet. One can give an even higher fiber diet. So it can prevent constipation in this kid. Even the kitchen feeds can be given. So the cost of the nutrition decreases, and it of course saves the feeding time of the caregiver. So more time can be given to physiotherapy and other aspects of the care. Now, there is a study which was published for the infants. So in this, the center from the Italy, almost 36% of the kids who underwent this procedures were the infants. And the median age at least was placed for 114 days, and the median age was 5.1 kg. You see the indication, the 48% were because of an HIE, and the other were other malformations, few of the metabolic disorders, chronic lung disease, any myopathies, other. So mean duration, so the procedure time was not very high, just 16 minutes, and in the field there could be initiated in a 2 days time. And there were very minor complications. There was hardly any major complication. And the one important thing is after, so it is a tube, so it has some life. So after average of 5 to 6 months, we need to change it to a low profile device. So generally in the average time of 5 months or so, we need to be converted into a low profile device that we call as a Mickey button. So the limitation of a tube is sometimes that it needs a GA, and when you are converting from a PET tube to the low profile device, you need another endoscopy procedure. So another admission, another GA, and sometimes those patients with a progressive neurological disorder, they may need a prolonged ventilation or some hours of the ICU stay. So now what we do is basically we can now introduce this Mickey button directly by using an introducer kit. So this is the kit that we get. So there are this blue colored one are the suture material. There are safety plexi sutures. And there is this long one is a dilator, trocar dilator, which is used for serial dilatation. So, and this is basically a balloon guided tube, or we can use the Mickey button also. This is how the low profile device looks. So this balloon internally is fixed into the inner side of the gastric wall, and this portion is outside. So this is only this much portion. So outside this only this ports are there. So it's very easy for the parents for they are going they are undergoing physiotherapy, and also there is no tube is hanging. And this tube is detachable, which can be attached and can be used for the feeding. Now in India, at the moment, because of the low use, we are only getting a 24 French dilator, which is only for the adults. So it's quite big, but we are able to use it till a 7 kg of kids also. But probably if the further the smaller diameters are launched, we might be able to use it for even the younger babies. So how we do this procedure? So this is again on the endoscope. We are in the stomach. We confirm the indentation. So then we have basically, we anchor the anterior wall of the stomach and the abdominal wall with the 3 sutures, that is called as the T-plexi sutures. So there are small needles. So the needles are introduced, and there is one anchor is there to the suture materials is anchor and it is anchored like this. So you can see the introduction of the first needle here. Yeah, this is the first needle, and then the suture is released from this needle. So somehow I'm not able to fast forward it to save the time on this. So this is how it's not progressing. Okay. So we place the three sutures like that, and then from the center of these three sutures, we place another guide wire, and then there is a serial dilatation is done, and then directly Mickey button can be placed over here. So from the outer surface, these are the three suture material which are placed, and we can put directly the Mickey button. The advantage of this is one, the single endoscopy procedure is required. If you are using a routine peg tube, probably for smaller kid, we can use a 24 French, 12 French. But with this introducer kit, we can directly use a 24 French tube for placement. So it's a big port which is a tube. So later on, whenever we are transition is going from the liquid diet to the semi-solid diet, so easily the thicker feed, more calorie dense feeds can be given. And the second procedure is not required to convert the peg tube to Mickey button. So it definitely saves one more admission, one more general anesthesia, and it's quite helpful for those children who has a progressive neurological disorder. So now let's move on to the second topic, that was the nutrition in more error of metabolism. Again, it's a very long topic and try to focus on few important aspects in this. So when we are dealing with an IEM in a neonatal age group, so they present, so the presentation, it can be intoxication syndrome like urea cycle defects, organic acidemia, fatty acid oxygen defects, or there can be reduced tolerance to the fasting like glycogen storage disorders, fatty acid oxygen defects, in the infantile hyperinsulinism, or sometimes there can be energy depletion disorders like pyrogenase dehydrogenase deficiencies or mitochondrial diseases. And there can be some pyridoxine dependent epilepsies, where disorders of neurotransmission. And there are some disorders where not much of the intervention is useful, like paroxysmal disorders. So whenever the patient, I'm not going to the details of the clinical presentation, but when the kids, when this baby is present with an emergency, there is some set of blood investigations that we do. That's from the blood and the urine. It's in any standard textbooks. Depending on that, we try to classify like what kind of disease probably I may be dealing with. Whether I'm dealing with organic acidemias, MSUDs, urea cycle defects, and any carbohydrate metabolism disease, fatty acid oxidation, or mitochondrial disorders. And then we decide like how to go ahead. The goals of the treatment here is, the first is to ensure the basic life support. Of course, they need to be in a good facility where is a good NICU backup, to provide sufficient energy supply, prevent accumulation of the toxic metabolites, correct acid-base balances, and introduce the supportive therapies like treat infections, manage convergence, and supply the cofactors, which is generally given empirical. So the first stage is you stop the feeding and give a high rate of the glucose. Then second stage is the correct acid-base metabolism, ensure good hydration, correct all the electrolytes. Look for any hyperammonia states, because that can directly correlate to the survival. If you are not able to manage ammonia, whatever you do, you are going to lose the child. So they will need either peritoneal dialysis, or depending on the age, might be hemodialysis also. So, so try to detoxify the ammonia and can use arginine, citrulline, sodium benzoates. Or if required, peritoneal dialysis or hemodialysis. Then promote, and once the acute phase is over, we concentrate on the promotion of anomalism by giving glucose, lipids if we are not suspecting fatty acid oxygen defects, so that there is good calories are given. After 48 hours, at least start 25 to 50% of the RDAs of the protein, because we don't give it fearing that supplementing the protein with increase in encephalopathy, there is the degradation of the endogenous proteins, and that will again going to worsen the nutritional status. For urea cycle defect, we restrict all amino acids, and if you know specific organic acidemia, we can restrict the specific amino acids. And of course, other supportive medications we go ahead. Now, this emergency management is the standard one, not going through in the details of all these emergency managements. Metabolic emergency drugs, again, this list is available in all the standard references. So one should know the doses and you should know how to reach the pharmacy to avail this, because when you are managing this patient, it's always the race against the time. Now when the acute phase is over, we focus on the nutrition of the kids. So we should know what are the needs of for the anabolism when the patient is in the infection, in the acute illness. So these needs are a little bit different from the standard one. So just refer and just try to see what are the, as per the age, what will be the required. Now, when you are focusing on the enteral nutrition, there are different kind of formulas. Just I think Dr. Bharti was also narrating. So we have, one is an elemental formula, similar elemental formulas, polymeric formulas, and there is a protein substitute. So polymeric formulas are those formulas which we use routinely where the carbohydrate fat metabolism, the macronutrients are present in the natural form. There is a polymers. Okay, so there will be non-hydrolyzed proteins and the carbohydrates provided by maltodextrins and oligosaccharides, triglycerides are these are the fat proportion. When they have been broken down to the pieces, we already get either partially hydrolyzed formulas, extensively hydrolyzed formulas, or elemental formulas. So in partially and extensively hydrolyzed formulas, we get oligopeptides. In elemental formulas, we get a single individual amino acid formulas, and the sugar can be either the maltodextrins or can be the glucose polymers, which can be again single, and the lipids is sourced by either the medium or long chain triglycerides. Now, as we go on and decreasing the size of the macromolecule to the micro or even the single one, the osmolality goes up. So we have to see the enteral tolerance, and also generally when you are a metabolic disease, they don't have much of the enteral issues. But when you are using these formulas for an surgical gut, short gut, there we need to consider this osmolality aspect. And then these are the protein substitute or the medical foods that is used for the patient who have the metabolic diseases. So one can use an elemental amino acids, or one can use the individual free amino acid can be a mixture, and whenever a particular disease condition, that particular group of amino acids is given less, and it is considered as the other essential amino acids are supplied. So that's how we have this is just basic understanding of the formulas that is available for the enteral nutrition in this process situation. So we know that the protein anabolism, so there are three aspects. So just by giving protein anabolism is not going to generate the protein supplement. So you need to provide good amount of calories, only then the anabolism will be spread. So we need to have carbohydrate, proteins, and leucine. That's going to stimulate the protein synthesis. And so what happens if we give an unbalanced nutrition? So if you're given adequate, there is a normal growth. But if there is an imbalance, so if you are giving more proteins but not giving enough calories, your protein are going to get wasted, and you are going basically have costly calories because they are going to get converted into the energy utilization. So if you are going giving less protein, then again the child is not going to gain the protein muscle mass, but is going to gain the fat. So that's why the balanced energy is very important. And we need to take the help of an expert nutrition. That is very important. As a clinician, we cannot do this, but we need to understand so that we know that what is happening in the right direction. And as a clinician, can you suggest any tweaking into the diet? So that's why we need to understand the diet in the special situation. So basically, the general tips are, we generally try to provide sufficient medical food to meet the needs, try to see the protein requirement as per the specific condition. So most of the guidelines are based on the phenylketonuria studies. And the more important is, do not over-prescribe the medical food because they are costly. You see, whenever there is an increased caloric need, depending on the stress, and when there are the conditions where you need to restrict the particular amino acids. So how to assess the protein sufficiency? We can assess biochemically by measuring the particular amino acids in the question. albumin, and of course the blood urea nitrogen. Anthropometric parameters you all know. And then again on the clinical assessment is very important, whether there are any clinical symptoms of malnutrition. So let's quickly go through few special conditions and let's see how we go. Suppose we had a child with MSUD, as the child is stable, and after stabilization you want to introduce the diet. So the goal is to maintain this leucine, isovaline, and valine. So individual assessment is not required, but if you do measure a plasma amino acid, yes, you will get this levels. So age, as per age, we try to see, okay, how much leucine is required, how much intact protein is required, how much total protein is required. So with this intact protein, you see how much, whether this minimum required leucine is getting, this requirement is met or not. Once that is been done, then then we supply the remaining protein with the medical food to meet the nutritional goal. And after that, we calculate the remaining energy required and use the appropriate fat and carbohydrate to meet the goal. So the formulas are there by different companies. So Abbott, Mead-Johnson's, DN stands for Denon Nutrition, and is the Pristine. I think in 2017-18, these formulas were launched, but however, they have been withdrawn because of a number of reasons. Now the Pristine ones are available and they are quite cheaper and affordable. So that's how, with the help of expert dietitian, you can calculate this and you can use these formulas. They are available in India. So whenever there is an illness, decrease the protein by 50%, increase the medical food, and you can increase the energy by increasing the carbohydrates and the fats. Now, if you are dealing the child with organic acidemias, again, here the goal is to maintain plasma amino acids in a normal range. So here, again, we see what should be the total protein and intact protein, and then you see what is the calories. So again, through the intact protein, we'll see how much we can give and whether the plasma amino acid levels in the blood is matched. It's a trial and error method. So, and number of things decide it. What's the catabolism, what's the basically basic metabolic rate of the child, and how is the liver is going to handle each amino acid. So you calculate the intact protein requirement, and what is the remaining you add by the medical food, and rest of the calories you fulfill with the other, like the fats and the carbohydrates. So the formulas for this, again, the Abbott, Amgen, and Nutrition are not available, and the Pristine ones are there available. But this group will definitely need carnitine, biotin, and B12. Now for tyrosinias, we do see these children quite frequently. So there's a plasma amino acid. So the plasma phenylalanine tyrosine should be maintained. So that's the goal. So here, important is when they are coming in the crisis situation, keep them NPO. You can get, and once they are stable, one can, again, so you see what is, how much phenylalanine the child is getting from the diet. Again, the same, use the same step and meet the another needs. And there are special formulas which will be free of the specific amino acids. And the Nutritional, so here in the tyrosinemia, apart from the diet, you need to give Nutritional, which is again, it is now launched in India. 2 years prior, the cost used to be very high. Now it is almost decreased to almost 50%. Now here, if the child is presenting to you and is less than 6 months, it's very important to identify this kids at early age. You can definitely start Nutritional and the special diet, and probably the cirrhosis can get reversed and child will have a good long-term survival with the Nutritional. But suppose you're diagnosing the child a little bit late, by 8 months, 9 months, so cirrhosis is already set. The kids with these conditions are already with high risk for an HCC. These kids have a micro hepatocellular carcinoma of 0.5 mm on all. So these are seen in the explants when kids are undergone a transplant as young as 1.5 years. There have been India studies which have shown that. So once the cirrhosis is set in, then even if you provide this, you may achieve a metabolic stabilization in the initial months or years of the treatment, but on the long term, these children are going to get decompensated because of cirrhosis, and they may still develop or have an HCC, and you may get a surprise at 5 years, 6 years. HCC is a slow growing tumor. So with the tumor which is already spread and is an unsalvageable case. So those children generally who present late, yes, we use this to stabilize them. But after that, this kind of kids, can need a transplant if they present at older age. The goal is to identify early. Also, we have to see the long-term cost. Now, the kids with urea cycle defects, so the goal is to maintain the normal ammonia. We have already seen the emergency management here. Again, the procedure is the same. Calculate the need to the intact protein, and you see whether the essential amino acids been maintained or not. Maintain ammonia as a normal, even if it's suppose they are clinically asymptomatic and the ammonia is high. So these children can have a learning disabilities. They can have a behavioral problem. They are hyper. They behave like an ADHD kid. So long-term good neurological survival is also important for the kids. And sometimes they have severe anorexia, so they can need an enteral support by either tube feeding or gastrostomy foods. The formulas are available for this, and one need to supplement L-arginine, except in the L-arginase deficiencies, citrulline, and nitrogen spacing medications, which has been already mentioned into the previous tables. Now, the long chain acyl coenzyme A deficient dehydrogenase deficiencies, again, they present as whenever there is a long-term fasting is there. Again, here we need to see how much LCT to meet the goal from the diet. Supply 50% from the LCT, supply 50% from the MCT, and then remaining of the energy need from the protein and the carbohydrate need. Again, therefore, the formulas are available. And what is important once to diagnose it? So there is some specific period of a meal per mouth. This can be tolerated. Younger the kid, smaller the interval. As the kid grows, maybe around 8 hours of fasting can be tolerated, but beyond that, avoid it. And these needs, they again DHA supplementation may be required once you are restricting the LCT. Just presenting one case. So it's basically a small boy, 3rd-degree consanguinity, and this child presented with an ascites, sepsis, lethargy, dehydration, and this child was from Surya Hospital, Dr. Ashwin. So this at the bedside, this child has a cataract, and there's a neonatal cholecystectin 6 baby. So it's a cataract sick child, it's in a galactosemia, but other problems like if you don't recognize in the neonatal screening, so the child presented with IV hemolysis, proximal rheumatoid cirrhosis, ascites, sepsis, was Klebsiella pneumonia. Fortunately, this child didn't have a meningitis. So this child and